All right, everybody, welcome back. So, after looking at our overview of the phases of the EMS call, we're going to go down and start drilling down into each one of those individual phases and really start talking about what occurs during those phases and how we need to approach our patient and what needs to happen there. So, what we're going to start with is the scene survey and patient safety. And this really starts out after the dispatch phase of the call. If you remember from our overview, that the dispatch phase of the call is where you're going to start developing your ideas, right? You're going to start thinking about what it is that that patient may need, and then you're really going to start developing a plan for that patient, right? So your primary assessment, or excuse me, your scene survey really starts with the dispatch information. You're going to start thinking about, is this a chest pain call? Is this an area I know? Is this a patient I know? Then we're going to get into scene safety as we arrive on scene. One of the things we're going to really talk a lot about during this short lecture is provider bias. Okay, this gets us in trouble a lot in healthcare in general. So we're going to talk about your preconceived notions about a patient based on some of the assumptions that we make when we arrive. We do know that certain healthcare trends follow certain demographics, certain socioeconomic status, certain patient populations are more at risk than others for certain pathological or disease states. But we have to make sure we don't let our bias get in the way of that. Okay. We'll talk about the environmental survey and what to do as you approach the patient and phasing into that sort of primary assessment. Okay. Remember that in this initial start of the call, right, this is really where patient assessment starts. In your clinical decision making, whether it's good or it's bad, starts as soon as that call is dispatched, right? You are the strongest assessment tool that you have and the strongest advocate for your patient, but you can also be the patient's worst enemy. So just try to keep that in mind as you go through and as you start to look at your patients. So with your dispatch information, and we talked about this with the overview, that remember that the dispatch information is subjective. The dispatcher can only relay information that they're able to get from the caller, and the caller has a worldview of what's going on, and it may be right, it may be wrong, it may be different than what's actually happening, but they can only convey from their perspective what they see, and the dispatcher can only then convey that information for you. So you need to make sure that when you get the dispatch information, for one, you should start developing a plan. Okay. You should start be thinking about, okay, this is a chest pain call or a respiratory distress call or a trauma. What things am I going to need? What resources am I going to need to have available? Do I need to have law enforcement coming with me? Do I need to have the fire department making sure they're on the way? Okay. All those things you should be thinking about during that dispatch phase, and you should be starting to develop your plan. But more importantly than just developing a plan, you also should be thinking about what if it's not, and what is my backup plan, and what's my tertiary plan. And so you should have a plan and an alternate plan for how you expect this call to go, and the ability to adapt and change to information as it comes in. Okay. Prior to arriving on scene during the dispatch phase, all providers should know their role. So if you are trying to be the lead paramedic on a truck, make sure you're having that conversation with your partner about what expectations you have when you get there. It becomes really important in things like critical patients or even in cardiac arrest. If you're getting a multi-agency response and doing a high performance resuscitation for cardiac arrest, I should know my role when I get there. Everyone else should know their role, right? You're going to go to the left side of the chest. You're going to be going to the right side of the chest. You're going to be on drugs. You're going to be on the monitor. So everybody should be able to know their role ahead of time. And if you guys don't have roles assigned, you need to have that conversation with your partner on the way, okay, to make sure they know what they're doing and you know what you're doing. Make sure that you are able to communicate well. Communication is key, not just with your patient, but also with your other providers, family members, bystanders on scene, okay? And we talked about the subjectivity there of information coming in from dispatch. So it's not uncommon to be dispatched out for one complaint and you arrive and it's something totally different. Okay. That information is subjective. Okay, so scene safety. We hear this a lot in education, and as students are learning to become providers. Is the scene safe? Well, I don't know. Is it? You need to be able to articulate what safety means. Okay, so you really need to be evaluating when you arrive on scene. Are there immediate hazards? Right, so you can see here in this image on the screen, it looks like we've got an arriving EMS unit, okay, arriving to an automobile accident scene where we've got fire department on scene here. They've got tools for extrication. We're in the middle of a roadway. It appears to be an accident. So the scene looks relatively clean and safe now, but understand that that can change. There are events that happen in our society that are unpredictable, and humans, the individual is the single greatest unpredictable risk anytime you're on a scene. People change, right? And people are unpredictable. So as you're arriving to this scene and you're looking there, you need to be thinking about what things are potentially dangerous. So, the cars aren't immediately on fire. There's not an immediate violent encounter going on. The power lines aren't draped over the roadway. Okay. It doesn't necessarily look like it's unsafe at the moment, but what may potentially make this scene unsafe later? Because those are also things that you have to be aware of. You have to have situational awareness. Okay. This road in this direction appears to be unblocked. Okay. Cars can travel down that direction and not be paying attention and run into another vehicle. That's a potentially unsafe or a hazard that may arise. You have this individual back here who's walking by. Maybe he just is walking, but maybe he has some other nefarious intention. So situational awareness is important with scene safety. Just because a scene is safe when you arrive doesn't mean that a scene is always safe, okay, or will stay safe, okay. This car, perhaps something has been damaged internally and it begins to smoke and catch on fire. The safety parameters have now changed, okay, and so you need to be prepared for that. As far as safety concerns go, the order of safety, right? So one, you need to make sure that you and your crew are safe. That's the priority number one. Because if you're injured, you now can't take care of other people that are injured, and you're adding to the number of injuries that are needing to be cared for. Okay, so you and your crew should be safety number one. The next is patient safety. Okay, make sure that you can safely get your patient. Let's say this scene starts to become unsafe. We may need to grab our patient and just move to the truck and get out of harm's way. Okay, and then resume our patient care later. There is an old sort of adage that, or you'll hear instructors or maybe peers or people in the profession talk about, watch out for the barking dog, right? It's the barking dog rule, right? The dog that's behind the fence and barking may be safe now, but if that dog were to be get out of the fence or get over the fence, then the scene then becomes unsafe, in which case you need to vacate. Okay, so safety is progressive, safety changes. The other thing that you'll hear is the rule of thumb. And what that means is when you're responding to an event and it appears to be something very dangerous. So let's say that there is an explosion or perhaps a chemical event. The rule of thumb says you should be far enough away from the scene that you can cover, if you hold your thumb up over the scene, right, that you can cover the entire scene with your thumb. If the whole scene doesn't fit behind your thumb, then you're too close. You need to back further away. That's the rule of thumb there. So we talk about safety, and safety is important. But there are times in our society and in our culture where safety has to be set aside. You have chosen to enter into a profession that responds to people in need, and not every time that a patient needs care, okay, are you going to be able to be 100% safe when you have to treat that patient. So, and we talked a little bit about this during the overview process, but things like response to terrorism. 9/11 was a tragic reality check for a lot of first responders, and I lived through that, and that will be something that sticks with me and my profession and how I move through things through the rest of my career and through my life, and likely influenced by people who have come after me. Um, there are times when we have to go in, and what appears to be a moderately safe or secure environment, as we all know, with September 11th, can very quickly become unsafe. Um, that's the job that we've signed up for, though. And so, when we have things like when we're responding to terrorist events or we're responding to active shooter events, okay, we may not always be able to be in a safe place, and we may still have to have a duty to act there, and may need to do our job. Okay. Um, so just those are things to keep in mind, right? Especially if you're early in your career, that we can't always hide behind, well, the scene has to be fully safe for me to go in. Because you, as the provider, have to exercise due regard and make sure that if you have a duty to act, you haven't breached that duty through reasonable cause. Okay. The other thing, there is a significant increase in provider violence, and we see this across all areas of healthcare, not just in EMS. We see this for nurses, for physicians, hospitals, nursing home staff. There is a continued push or continued incident rate of providers experiencing violent attacks from patients, from family members. This is a very real thing, and I would argue that if you talk to just about anybody who's been doing this job for any length of time, they would have a story to tell where a provider, or where they as the provider had a violent incident occur. So that makes things that were potentially safe become unsafe. It happens. I want to talk about abandonment for a little bit. Abandonment and malpractice. Once you have been determined that you have a duty to act, okay, so that you are a provider, and you have a duty to act. Malpractice is the definition. The definition of malpractice is that you've had a duty to act, that there was a breach of duty, and that breach of duty has resulted in some form of injury to the patient, okay, whether it's physical, emotional, or otherwise. Abandonment is when you have initiated care or announced yourself as that healthcare provider, and then you leave that patient to a lesser level of care, or you stop caring for that patient at all. Okay. And so, an example where this often occurs, and this is something that you as the provider can be liable for. Okay. You arrive on scene and there is a car accident, and you've got 10 patients or 7 patients, and you and your partner can only take 2 or 3 patients to the hospital, and you need more resources, and you've called for those resources to come in, but they've not arrived yet. But you decide that you're going to take 2 patients and go on to the hospital while the other crew is on the way. Technically, you've initiated care for that entire scene, so whatever patients are left, you've abandoned those patients, and you could be potentially responsible for any injuries that occur to those patients while they're at home, or while they're on scene and they're waiting for a handover of care. When we get into trauma, we'll talk about the triage criteria and triage rules so that you can help make some informed decisions about who gets treatment first. But once you initiate care, you can't just stop. Okay, you can't just stop care. So that's something to keep in mind. The other time that we see this is you're in a busy service and you are in a call for service. You've taken a patient to the hospital and you're waiting on a nurse to come to the room, but you've got more calls that are backing up and you just got to go. So you leave the patient in the hospital without giving patient turnover. That's also a form of abandonment. Okay. Your duty when you arrive to a patient is to that patient, and you should see that through all of the patients that you've arrived to take care of. Okay. You should see that through until to finality, right? So either to a handover of care or terminating a care, whatever that may be. Okay. All right. So let's talk a little bit about provider bias. This, hopefully, if you're new coming into the field, This is not something that you're gonna have. But if you've been in EMS for any period of time, or been in healthcare, or perhaps fire or law enforcement, you're certainly going to start to develop provider bias. And what provider bias is? The information that you get from dispatch that you've decided it's that patient, right? Oh, it is that patient, it's that person, it's this individual. You get dispatched out to a common address where you know the resident of that address, you know that they're perhaps an alcoholic and they're always just drunk and they call you every time, right? Or what we consider frequent flyers in EMS, or frequent users of the system. Oh, there's nothing wrong with Joe today. He's just calling because he's bored, right? That is a surefire way for you to miss what's going on with your patient and cause what would potentially be significant harm to that patient, either by malfeasance, doing something that results in harm, or nonfeasance, not doing something that would prevent harm for the patient. Okay? Check your bias. We all have them. They all are going to pop up. They're all going to rise, and you're going to have them. There's no way you can be unbiased to every patient you see. You're going to develop bias in healthcare. You do in most professions. It's also known by another term, complacency. Okay? So depending on where you are. In healthcare, we call it healthcare bias, okay, or provider bias. So try and check your bias, right? Remind yourself that just because it was this way last time, just because Joe was drunk last time, or Joe was bored last time and needed to call 911, doesn't mean that it's not something different this time. Doesn't mean he can't have an MI, a heart attack. Doesn't mean he can't have a traumatic event, okay? The other thing you have to keep in mind is that emergencies are subjective. And what I mean by that is that the patient's perception of what's occurring in their life, that they've picked up the phone and dialed 911, is an emergency to them, regardless of whether or not you think it's an emergency. Your experience in the field as an EMS provider, as a healthcare professional, gives you perspective that the layperson doesn't have. So that means that you may know that a stubbed toe is not an emergency, no matter how bad it hurts. The patient doesn't necessarily know that. Okay? So while we talk about patient bias or provider bias, make sure that you are also reminding yourself that you have perspective that the patient doesn't have, and that their emergency, no matter how routine it may be for you, is not always needs to be dismissed, right? You need to give the patients the respect and the dignity, because they feel that what they're experiencing is emergencies. Okay. All right. Other parts of the scene survey, right? The environmental survey. This is a process that's largely ignored by most providers. They really get tunnel vision and going right to the patient and not really focusing on what's going on around them. So with the environmental survey, things that you're looking for, and we mentioned a lot of these in the overview lecture. Okay. The patient's environment that they live in can tell you a ton about their access to healthcare, how they're able to move, do they have good mobility, do you risk things like food insecurities? Okay, your environmental survey is not just for scene safety, but you're also trying to get indicators for how the patient lives. If I arrive on scene at this house, I'm looking at a dilapidated residence. I can see that clothes are hanging up outside. There's the buildings falling over. There may be safety issues for one, but there also may be things like the patient can't get up and move around, right? Maybe they have restricted mobility that may increase their risk for deep vein thrombosis. Okay, probably don't have access to high quality nutritional food. Okay, that may increase the complications with things like diabetes or high blood pressure. Okay, so keep in mind that you have to assess your scene and your environment, the patient's in, to not just assess for scene safety, but assess for the patient's overall health quality. Okay, and we talked about this in the overview as well. You're the only person in the continuum of care that's going to see the patient where the emergency started, right? None of the nurses, none of the physicians, none of the discharge planners, none of those folks are going to be able to see the patient in the environment that they're in. So it becomes important to be able to convey that information during your patient handover to make sure the patient gets the most appropriate care. And then as you've done your scene survey and your environmental survey, you're going to start to approach the patient. Again, you should look at what's immediately around that patient as you approach the patient. Okay. And what I mean by that is you have patients who are oftentimes bedbound or chairbound, and their whole world is right around them. And so, on the couch side table that they're laying on or near, you'll see, a bag of to-go food, maybe all their medicines, a drink, a can of soda or something. It looks like their whole world is right there. That tells you about the patient's ability to get up, to be able to move, to be able to go seek medical care, right? Maybe they've not been able to seek medical care for an extended period of time. Okay. So look at the patient's position or their immediate environment around them, and then look at their positioning in the environment. Okay. Are they in an unnatural position? When someone has a syncopal episode and goes unconscious, okay, they typically fall and land in a way that's not a natural lying position, right? Did they look like they were intentionally laid down and put themselves in that position, or did they fall? Okay. And watch the demeanor of family and bystanders, right? That's your clue into what happened, right? What were those events leading up to? So make sure that you get all of that information and think about all of that as your patient. And then as you get up to the patient, the next thing you're going to do is your primary assessment. And this is your A, B, C, D, and some folks, depending on where you are or what you read, they may add E in there as well. So A is for airway. You're going to check for airway obstructions. Okay. B is your breathing. You're going to check for rise and fall of the chest and breathing effort, right? Are they able to breathe easily or are they struggling? C, you're going to check pulse, right? Reach down, grab a quick radial pulse, skin color, temperature, make sure they're not bleeding anywhere. Okay. D is disability. That's the AVPU. You remember we talked about level of consciousness. Okay. That's alert to verbal stimuli, alert to painful stimuli, okay, or unresponsive. You can check their pupils. I would argue that you're probably going to check the BGL, that's their blood glucose level, later during the secondary assessment phase. Okay? Because based on this information in your primary assessment, this is where you're going to make your transport decision. Remember your acronym CUPS, right? They're going to be either critical, unstable, potentially unstable, or stable. And we're going to decide now, with this information, without going any further, whether they're a stay and play or a load and go sort of patient.